Hello. Welcome to our Comprehensive Transplant Center at Northwestern Medicine. I'm Dr. Juan Carlos Caicedo. I'm the director of the Living Donor Liver Transplant Program here at Northwestern Medicine. In this presentation, I'm going to provide an overview of the living liver donation process. We're hoping that this information can be helpful for you at home. You can review it with your family and friends. Please take notes and write down your question. And we look forward seeing you soon here at Northwestern Memorial Hospital. And our team will be more than happy to answer all your questions. Let's start providing some historical perspective. Living donor liver transplantation started in 1989. The donor was an adult and the recipient was a child. Then that donor gave the left lateral segment. And the left lateral segment is this area that I'm showing here. In 1993, the left lobe was used for a small adult. And in 1996, the right lobe was used for donation, the first time in Asia. And the first right lobe living donor liver transplant was performed in U.S. in 1998. Over 7,000 living donor liver transplant has been performed here in the country for adults and children. Northwestern Memorial Hospital started its living donor liver transplant program in 1997. We performed the first left lateral segment for a kid in Children's Memorial Hospital. And in August 1999, we performed the first right lobe liver donation for an adult recipient. From them, Northwestern became one of the biggest living donor liver transplant programs in the nation and participate in the probably most important living donor liver transplant study, the A2O, adult-to-adult living donor liver transplant study. There is a survival benefit when patients receive a living donor liver transplant, and that was one of the most important conclusions from the A2O study. There was a significant survival advantage associated with receiving a living donor liver transplant instead of continue waiting for a deceased donor liver transplant. Across the range of MEL scores, even if the MEL score is below 15, in patients without hepatocellular carcinoma, they will have a significant survival benefit when they undergo a living donor liver transplant rather than waiting for a deceased donor liver transplant. For patients with low MEL score, if they have ACC, don't receive a survival benefit from living donor in this study, but there was another study actually that showed that there was a benefit of living donor liver transplantation compared to waiting for a deceased donor liver transplant in patients with ACC, but if they have a waiting time longer than 7 months. Well, if you have a living donor, what are the next steps? Then the first step is the donor needs to contact us. They need to call the living donor liver office. It's very important that it's a voluntary decision without conflict of interest, no coercion, no payment involved. This potential donor needs to be healthy, without medical comorbidities, with a normal weight, and willing to do it freely. They need to complete the 4 phases of the informed choice, and these 4 phases start with an information session. The whole process is confidential. The idea is trying to protect the donors also all time. Donors must be healthy and meet the Northwestern selection criteria. Our goal is to minimize donor risk. Donors must be given every opportunity to change their mind. We emphasize all the alternatives that the recipient will have as well alternatives the donor will have. And the communication between the donor and the transplantee is key. Now let's talk about the donor evaluation. Then the first thing is to determine what is the blood type of the donor to make sure it's compatible with the recipient. We're going to obtain a history as well physical to make sure there's no medical contraindication, surgical contraindication, or psychosocial contraindication. We're going to review the med list, and we're going to stop some medication that could increase the risk of complication. For example, oral contraceptives can increase the risk of clots in the veins or pulmonary embolisms, and then we'll stop it prior to surgery. We're going to do some blood tests and serologies, liver numbers. We're going to evaluate the liver using imaging. We're going to do MRIs, and we're going to look specifically for the arteries, veins, bile ducts, and sometimes some potential donors may require liver biopsy. And depends on the age or some specific circumstances, some donors may require cardiac testing. And based on the donor age, it will be necessary to have a cancer screening, then sometimes mammograms, PSA, or colonoscopies. After a donor has been approved, it's important and for the patient to maintain their health status, maintain their weight, and make sure that they maintain their support system. If something changes, that could delay or cancel the planned donation. Then we need to know, and then we're trying to help you in any fashion that we can do. We have a large team, as you can see here, that has been working in living donor liver transplantation for more than 20 years, as I mentioned before. And we have multiple members of our team that speak Spanish, and we can provide care for our Spanish-speaking patients. We have 2 surgeons as well, 2 hepatologists that are Hispanic and are Spanish-speaking. Now, the timing of the donor evaluation is dependent upon the severity of disease of the recipient. And then the phase 1 is when the donor initially contact us to the transplant center. Then we're going to ask you about the ABO compatibility. We're going to do an initial screening phone interview. Usually it's our living donor nurse. We're going to ask you about your age, weight, height, medical surgical history. We're going to check your medication, and again, we're going to verify the ABO compatibility. Phase 2 happens when the patient has been cleared in phase 1. Then now here's where we're going to start seeing the potential donor. Then the first person that is going to see the potential living donor is our independent donor advocate. It's a social worker that will talk with the potential donor, and if there's no contraindication in the psychosocial point of view, the psychiatrist also will complement the assessment, or the psychologist, and if they don't see any psychosocial issue, then we're going to have one of our liver surgeons and one of our hepatologists to see the donor, and we're going to update the cancer screening, and the donor is going to receive some information at the end of the evaluation day. Phase 3 actually is the same day of phase 2, and if there's no medical, surgical, psychosocial identified by our team, Then we're going to do some blood work, as well imaging. We're going to do an MR, MRI, MRA, MRB, MRCP. That means that we're going to evaluate not only the liver by itself, the volume of the liver, but also we're going to check for the anatomy of the hepatic artery, the portal vein, the hepatic veins, and all the structures that the liver has. In the phase 4 is when we're finishing the process, and now we're trying to set up the OR, and we're going to provide more education for the patient and family. We're going to repeat some blood work within 2 weeks of the scheduled surgery. We'll repeat chest X-ray. We'll do some blood work that must be done at Northwestern Memorial Hospital. And as I mentioned before, they were going to receive more information, or we're trying to answer any question that they may have. And usually this final phase 4 is 2 days prior to the scheduled surgery. We'll do a history and physical, and final test in the EKG, chest X-ray, and labs. And the patient will be admitted to the hospital the morning of the surgery. Now, the protection of the donor is the number one priority for us, no matter how ill the recipient may be. Anytime prior to the donation, a donor may change their mind or request reassurance. Protection of the rights and well-being is the top priority. Now, talking about the surgery, and actually, by the way, this is our team in the OR, then the first question always is how much liver the donor can donate, as well the recipient will need. Then in this graph that actually show us, even though the liver is a single organ, it's a very complex organ. It's a wonderful organ, because even if you resect 60% or 70%, by 3 months, the liver will grow back, will regenerate. It's the only organ in the human body that can do that. Then, depends of the so many factors, but one of them is the recipient weight. Then we will need to use different size of liver for the transplant. If we have a normal size adult, more than, for example, 60 kilos, then usually also will depend on the size of the donor, where we'll have to use the right lobe, that is here. Then, and when we are considering to do a recipient that is a small adult or a kid, then sometimes we have to, if this recipient weight between 25 or 60 kilos, usually, and also depend on the size of the donor, we're going to use the left lobe. And if we have a baby, for example, or a small pediatric recipient that weighs less than 25 kilos, then usually what we have to transplant is the left lateral segment, the left side of the liver. Now, when we are removing the right lobe of the left lobe, our transection plane of the liver is going to end up where the gallbladder is, and that's why always we remove the gallbladder when we're resecting the right lobe of the left lobe. And the liver will regenerate not only the donor, by 3 months, as I mentioned, will be almost as big as before donation, but also will grow in the recipient. Even if we transplant a small piece of liver, the left lateral segment, in a baby, that liver will grow with the baby, and whenever the baby become adult, he will have or she will have a normal size liver. Now, for recipient as well donors, adult donors, the liver is 2% of the body weight usually. Then for recipient, optimal amount of liver that needs to receive is around 1% of the graft I'm sorry, 1% of the recipient body weight. Then there is a ratio between the graft and recipient weight, and when that ratio is more than 1, usually it's safe to proceed with transplant. We can go lower, but we have to keep in mind other considerations. Depends on how sick is the patient, if there's portal hypertension, or other medical issues that may affect. And if we have a 7-kilo recipient, usually we need at least 700 cc's liver. Again, sometimes we can go lower, but that can increase the risk of small forsyth syndrome. And that's why it's so important to determine the volume of the liver, and we're doing that using the MRIs. For donors, again, usually 2% of our body weight is liver. If we're resecting up to 30%, we cannot go beyond that, just for the safety of the donor. We don't want the donor to develop liver failure because we resect more than that. Then usually we have to keep in the donor at least 30% of the total liver volume. And again, we determine the volume of the liver using MRIs, and sometimes you can use a CT scan. Now, as I was mentioning before, we can resect big areas of the liver for adult recipients, and that liver will grow, will regenerate in 2 or 3 months. And then for smaller kids, we can use smaller areas. Now, here is just a diagram that can show us how could look a right lobe after we divide it. Then, as you saw before, there was multiple structure going to the liver. In blue was the portal vein that here is just divided. The artery is in red and was already divided, and the hepatic vein was already divided here. And then when we're doing the transplant, we're going to reconstruct, or we're going to anastomose that right hepatic vein directly to the inferior vena cava, and the portal vein we're going to anastomose or create a new joint between the right portal vein to the portal vein in the recipient, as well the bile duct and the hepatic artery, as is showing here in the diagram. Now, let's talk for a second about the living liver donor incisions. The traditional incision is the Mercedes vein incision, and this is the incision that most of the liver transplant recipients got. And that was the initial incision for all living donors, and multiple teams were trying to minimize the size of the incision and start doing hockey sticks incisions, and the other option is just midline incisions, where instead of Mercedes veins or hockey stick, through the midline incision, we resect the liver, we remove the liver. And that is the way that we do it here in Northwestern. This is a hybrid method. This is a laparoscopic assisted procedure. Actually, we performed the first laparoscopic assisted right donor hepatectomy in the world in 2006, and that is the way that we're currently doing here in Northwestern Memorial Hospital. And that helped for patients to recover faster after living donation, as we're going to discuss in a moment. Then this is one of our patients. We do a midline incision. We place 2 laparoscopic ports. One of the ports in the right upper quadrant is a 5-millimeter port, and there's another port in the mid-abdomen, and that port is going to be that incision is going to join the midline incision, and at the end, this is what the patient is going to see: just a midline incision plus a 5-millimeter port on the right upper quadrant, And through that right upper quadrant incision, we place the JP, is a drain, after the surgery is completed. Then the incision is closed with absorbable sutures. We don't use staples, and no suture needs to be removed after surgery. Now, the day of surgery, the patient is admitted in the morning. The donor hepatectomy usually takes 4 to 6 hours when we're doing right lobe or left lobes, 3 or 4 hours for left lateral segments. And usually, if we're doing just a left lateral segment, this patient go to recovery room and then to the floor the same day. But if we're doing a left lobe or right lobe, usually this patient is transferred to the ICU at least for 24 hours. Then patients are going to have multiple tubes. They're going to have IVs, usually in the arms. They're going to have a JP drain. This is a JP drain picture. This is what is going to be inside of the patient. And the JP drain is used to remove from their abdomen any type of blood, fluid, or bile, if there is any. Usually we keep the JP for a few days. And also we're going to place a Foley catheter. This is a Foley catheter that is going to be in donor bladder to drain the urine for the first few hours, as well a nasogastric tube. And that tube, as well, the Foley will remove the next day after surgery. Now let's talk about the hospitalization course. Then the patient is transferred to the floor in the post of day 1, the first day after surgery, if it's a right lobe and left lobe. If it's left lateral segment, the patient is transferred directly to the floor the same day of the operation. Patients need to start walking as soon as possible. Why is very important? Why? Because decrease the number of complications, including clots in their veins, DVTs, and those clots can migrate to patients' lungs, and people can die from that, and we want to avoid it. Then actually that's why before the operation we're giving blood thinners to minimize the risk of clots. During the operation we're going to place a special pneumatic system in your legs that are going to provide some massages during the operation that will improve the blood flow in your legs and will minimize the risk of clots in your veins and will decrease the chance of pulmonary embolism. As well, if patients start walking, that will improve the blood flow in your legs or donor's legs, and that will decrease that type of complications. As well, if the patient start walking, that will improve the pain. Why? Under general anesthesia, the bowels become sleepy, they become distended, that increases the abdominal distension, increase the abdominal pain. But if people start walking, the bowels will move, they wake up, they will start contracting, passing gas, that will decrease the abdominal distension, will decrease the abdominal pain. Then it's really, really important to start moving as soon as possible. Patients can start drinking some fluids after the NG tube is removed in the first day after surgery. They're going to have IVs. Then, as I mentioned before, we're going to remove also the Foley catheter in the first day after surgery. Usually, patients or donors are going to be discharged from the hospital 2 to 3 days after surgery. Usually, if the pain is under control, if they can pee without Foley, if they can eat, if they can drink, if they can walk and take care of themselves, and if all the daily activities have been normalized. Then after the transplant, we're going to see the patient multiple times. We're going to see the patient 1 week after the surgery, 1 month, 3 months, 6 months, 1 year, 2 years, 3 years, or whenever the donor needs it. Then usually in the first visit that happens 5 to 6 days after surgery, the independent donor advocate is going to see the patient, the transplant surgeon, the living donor nurse also is going to see the donor, and then she will help to remove the JP drains that most of the time is still in place. What happened in that visit? Then again, we'll remove the JP drains if there's no signs of bile leaks. We're going to discuss about pain control. We're going to help to modify or transition the pain medication to make sure that we stop the medication as soon as is possible, usually 7-10 days after donation. Then we're going to assess the hepatic function, the incision, and we're going to talk about the support that patient has, and again, assess the daily activities. Now, in the first 6 weeks after surgery, it's very important for patients to avoid any type of heavy lifting, no more than 15 pounds, because we want to avoid the risk of developing hernias. That's why patient needs to avoid vigorous activities. They can be active, but no doing extreme activities. No swimming, bathing, or hot tubs. We want to make sure that the incision heals up nicely. And then in the first 3 months, patient needs to avoid any type of alcoholic beverage and no protein shakes. And again, daily activity is important. Patients, if they need to cough, they can hug themselves to minimize the discomfort associated with the coughing. The coughing is very important, as well the deep breathing to avoid the collapse of the lungs that is a risk factor not only for fever but also for developing infections of the lung called pneumonias. Now, the patients can start having some fluids by mouth and soft diet the first week. They can advance as tolerated after the first week, especially if they're having normal bowel movements. Medications, again, we're going to prescribe pain medications as needed. Usually these medications like Norco can generate some type of constipation. They can generate nausea. And that's why many of our patients require stool softeners or medication for nausea. As well, patients or donors are going to receive electrolyte replacement daily for the first few days. This is very important because those electrolytes will help in the regeneration of the liver. Then initially is very important. And usually patients consume a lot of these electrolytes, and that's why we have to replace it initially. Now, it's very important for donors to understand that there's potential complications. These include but are not limited to surgical complications, medical complications, or psychosocial contraindications. The most worrisome complication is death. Death has been described in living donors. It's not very common. It's very infrequent, but has happened in the world, has happened in U.S. Thank God it hasn't happened here in Northwestern. There's severe bleeding. There could be bile leaks, or biliary stenosis, vascular stenosis, or thrombosis of the hepatic artery, portal vein, hepatic veins, infections, pain, organ failure. Donors may require liver transplant, hernias, blood loss, transfusion, or complications associated with the transfusion, complications related to general anesthesia, and the scar, and reoperation for complications. Now, one of the most common complications after donation is fatigue. Usually donors feel tired, usually for a few days or a few weeks. Nausea, vomiting, or bloating, blood clots and pulmonary emboli, cardiac arrhythmias or cardiovascular collapse, pneumonias, artificial ventilation, organ damage, organ failure, arm numbness or brachial plexus injury, nerve damage, ileus, bowel obstruction. Then it's also important to mention, even though complications may happen, most of the time, 95% of the time, those complications resolve without any type of sequela in the long term. 5% of the time, on long term, what may happen is, for example, hernias that maybe don't happen initially after the surgery, but may happen 1 year or a few years after donation. If that happens, we'll take care of the donor, we'll repair the hernia if that is the case. The other potential long-term complication is psychiatric disorders, depression. And that's why part of the evaluation, even before the hepatologist, the surgeon, see the donor, our psychiatrist and independent donor advocate, social worker will see the donors to make sure that they are suitable for the donation in the psychosocial standpoint. Then all other potential complications is wound infections, inability to return to work secondary to complications. Other potential complications are psychosocial complications, the body images, a scar, or maybe the issue is that recipient is not doing well because there's hepatic artery thrombosis, or there's a vascular complication or biliary complications in the recipient, or the liver has failed requiring retransplantation, or there's a recurrence of the disease, or there's rejection, or there's depression, or post-surgical stress or anxiety or guilt in the donor after donation. There's also potential financial complications like inability to obtain health or life insurance coverage, possible denial of coverage, loss of employment, financial hardship, lost wages related to donation. And in kidney donors has been described that 3% of them are having difficulties getting future insurance approval. That's why it's important also to discuss all of this prior to donation. Regarding billing information for the living donors. At times, a donor may receive a bill during their evaluation or after the donation surgery. These bills are not your responsibility. Usually, all the evaluation, the surgery, and follow-up costs is paid by the recipient insurance most of the time. If you receive any type of bill from Northwestern Memorial Hospital or outside facility, please contact our transplant performance manager. Now, here are a few pictures about the liver. This is a cirrhotic liver. It's ugly with a lot of scar tissue in it. And this is a beautiful, healthy donor liver. When we're doing surgery, we use a lot of instruments in the OR. Here you can see some retractors, some surgical instruments. Sometimes we have to use a cholangiogram during the surgery. We will use eyes to maintain the liver graft preserved while we are removing it from the donor and we are implanting it in the recipient. And we use a special preservation solutions. Here is just showing a picture of a cholangiogram, and this is the ventilator, the machine that anesthesia used to keep the patient under general anesthesia. Then when we remove the liver from the body, we're going to perfuse the liver with a preservation solution to preserve the liver and to be able to perform the transplant and make sure that the liver is functional after we perfuse the liver. Common questions that some people have about this process. Does the potential donor need to be a relative of the recipient? And the answer is no. No, donors could be relatives, could be the spouse, or could be family and friends, and sometimes somebody that you don't know. Sometimes people are motivated to donate the liver. They are considered non-direct donors. They donate the liver to somebody else that they don't know. Also, what we need to tell, what we can tell the donors that are ruled out for any medical, surgical, psychosocial reasons. In our mind, anyone that decides to move forward to do the first step in the donation process is already a donor. But if they can't donate, at least they can become a donor champion or a recipient champion, meaning that they can help them to find another potential living donor? It is necessary to find multiple potential living donors? And the answer is yes. Why? Because around 60% of the donors are ruled out due to medical, surgical, psychosocial conditions. And if you have any questions, you can call our living liver donor nurse anytime. And it's also important for you to know the alternative for the recipient. We can choose another donor if you can be a donor for any medical, surgical, psychosocial reason. Or the recipient can wait for a deceased donor. And if a deceased donor become available and there is an approved living liver donor, the recipient will have the option to accept the deceased donor or move forward with the living donor, if that is the case. And also there is an additional education material you can find in YouTube, a very interesting talk by Dr. Michael Becasis, where he's answering the question if there is an ethically acceptable threshold for liver donor risk. There's also a lot of information for patients and family in the UNOS website. And there's toll-free numbers, and there's UNOS patient service line, and these can help transplant candidates, recipients, family members understand organ allocation and transplantation data, or for general transplant information. Also, there's different health learning centers here in Northwestern in different floors across our hospital. And also, patients can visit the SRTR website. It's very helpful when you want to learn about outcomes, patient and graft outcomes in different transplant centers. You can compare, all the information is available, nothing is a secret, and everything is available to anyone on the web. And every 6 months, there's new data from all transplant center outcomes. And most recent data report will be attached in your education notebook that you will receive as soon as we see you here in Northwestern Memorial Hospital. And again, as I mentioned at the beginning, if you have any question or your family members or your loved one or friends have questions, write it down. And as soon as we see you here in our clinic, we'll be more than happy to answer your questions. Thank you very much, and we look forward seeing you soon. Have a great day. Thank you.